So my name is Joe Castiglione. I am part of the Industry Initiatives team here at Blue Shield of California, and I lead our team's portfolio of work around primary care. I have the immense privilege to be the moderator for today's event, and I'm joined by an incredible panel of experts. We have Dr. Cameron Matthews of City Block Health, Dr. Rishi Manchanda of Health Begins, Dr. James Cruz of Blue Shield of California Promise Health Plan, so that's our Medicaid health plan. And finally, Dr. Laura Gottlieb of University of California, San Francisco. I will ask them all to introduce themselves in a few moments, but let's start with a few housekeeping items. We have an attendee poll that should come up for you here. We would love for you all to share the type of organization or entity you represent, or if it's yourself, would love to hear that too. That will help our speakers today sort of tailor some of their talking points to the specific audience that we have present. A quick reminder that all lines are muted, so if you have any questions, please use that Q&A box, and we will get to those a little bit later in the event today. The chat the chat function, the comment function will be your feature for both technical assistance. This Zoom world that we live in now can sometimes be challenging. So feel free to use that chat function for any questions you have, but also comments. You know, as much as we would love for this event to be in person, unfortunately it's not. But use that comment function or that chat function as if we were. You know, we have found through doing these events that they're most meaningful when the events are grounded in stories that remind us why we're here. So if you're open and you feel comfortable, as the conversation flows, we would love for you to share stories that come up for you. So that really helps sort of make this work, or sort of illustrate the impact that this work can make and ground the conversation in humanity. We will send out an event recording. It is being recorded today, so please make sure you're registered with your email so we can share that with you. And finally, please tweet if you are a tweeter. We do have some handles here for you to use. Okay, so before we jump into content, we met with our speakers leading up to this event, and all of us sort of agreed around the need to explicitly acknowledge the legacy of structural and systemic racism and discrimination that we have in our healthcare system. It is a part of our social fabric. So unfortunately, it's not altogether unsurprising that we see it in healthcare. And as institutions, as health plans or hospitals, providers, technology vendors, policymakers, we have to recognize that the inequities we see today are a direct result of racism and discrimination. So I just want to encourage all of us to hold ourselves, our institutions, and each other accountable, because it is incumbent upon us as upholders of this system to change what is broken. So having said that, I want to give you a quick thank you to the audience. This is the third and final of our event series on primary care, and many of you have been with us for all of the events in this series starting back in December, and we are immensely grateful to you all for showing up and engaging. So I want to hand it over to Chris Koller, Milbank, our partner on this series, Milbank Memorial Fund. We are fortunate to have Chris Koller here with us today. So I'm going to pass it over to Chris to say a few words and sort of set the table for us.
Thank you very much, Joe, and welcome everybody. I want to thank Joe in particular, but Blue Shield in California for their leadership throughout this series, in particular for landing on this issue. As Joe said, I'm going to try to frame this at the start and then hand it over to the great panel that Joe and his colleagues have been able to assemble for us. We're talking about scaling action on social needs and the role of primary care, but as Joe said in his leadoff remarks, I want to just sort of base this on this notion that we care about this because there is a fundamental value that we are asserting in equity. And that's based in turn on a fundamental belief in the dignity of each human being. As Paula Braverman has put out what's commonly used as a definition of health equity, it means that everyone has this fair and just opportunity to be as healthy as possible. And we value that because we value individuals. As Joe acknowledged, to do work on equity means to acknowledge specifically the harms of inequity. I put an example here from the American Medical Association statement they put out recently, where they talk about the power to push forward or toward a more equitable future means acknowledging, reversing the historical harms that we have caused. That often can be hard to identify, the way that we might individually participate in inequity. Or in our case of the Milbank Memorial Fund, we have a very particular example of that. When we look at our legacy, we actually supported the study of untreated syphilis in Tuskegee and Macon County starting in 1934. So we've had to confront that ourselves, and I think that really grounds our approach to equity and why we hold it important, why we're actually including it in our mission statement. By the way, if you want to learn more about that, feel free to go to our website where we have the documents put up. But for us to be serious about scaling action on social needs, we have to value equity, and that means acknowledging the harms of inequity and our own participation in it. Next slide, please. And when we talk about primary care, we are not merely asserting, but there is evidence that primary care is vital to improving health equity. It's the only healthcare service where greater high quality supply results in more health equity. Barbara Starfield and her partners put that forth. Some of that information published in our own Milbank Quarterly. And when we talk about high quality primary care, we're not talking about any primary care. We're talking about primary care as envisioned by the National Academy of Science, Engineering, and Medicine, which emphasizes interprofessional teams addressing the majority of healthcare needs across settings and through sustained relationships. That's what we mean when we talk about primary care. And finally, we're talking about social needs. If we are to achieve health equity, we have to address the social needs, which drive much more of health status than the quality of care. You have the continuation of Braverman's definition around the importance to the obstacles to good health. She's got the examples here that we often lump together as social needs. Primary care is essential to that work. It's a point of trusted contact where we can start to engage people around the social needs, but that requires evidence around what works. It requires payment so that that kind of work is possible, and it requires alignment across payers. And that's exactly the wisdom of what Blue Shield's been able to assemble here. We have a group of experts. We're going to talk about the evidence around how you connect primary care practitioners to social needs and to the folks who need them, what sort of payment is necessary to do that, and how you get alignment across payers so we can do this work and make real progress on it. So I hope that gives a grounding for why we're here and the work that we are doing together on this stuff. And I'm pleased to hand it over to a set of panelists who are going to present very specific evidence around how you actually do this work, linking primary care to social needs and scaling in a way that improves health equity for everyone in the country. Thank you very much.
Thank you so much, Chris. Your partnership on this has been just essential, and we would not be here without you. So I do want to start by calling out the results of our poll, if we could get those. Great, so looks like we have lots of representation from health plans, health systems, nonprofit, government. So lots of folks represented today, a huge diverse audience, and we are so thankful to all of you. So we're now gonna have each of the speakers introduce themselves. Again, I am so excited to bring you a panel of clinical experts and innovators who can sort of help us understand how and why we need to empower primary care with the tools and resources to address social needs. So I'll turn it over to the panelists to introduce themselves. Let's start with Dr. Cameron Matthews.
Thanks so much, Joe. Thanks everyone for, I hope to be a really engaging conversation. Cameron Matthews, I'm a family physician and I'm Chief Health Officer with City Black Health, a value-based provider focused on Medicaid and dual eligible communities.
Thank you so much. Dr. Rishi Manchanda.
Joe, thank you so much. And hi, everybody. My name is Dr. Rishi Manchanda. I'm a primary care med-peds trained physician, CEO at Health Begins, a national mission-driven firm that helps healthcare systems advance health equity, specifically by addressing the social and the structural drivers of health equity. It's a pleasure to be here.
Thank you so much. Dr. Cruz.
Yes, good morning, and thank you for inviting me to be part of this impressive panel today. And I also want to thank you, Chris, for sharing those very important opening remarks. As mentioned, I'm James Cruz. I'm a family physician by training, but I'm also the Blue Shield of California Promise Health Plan Chief Medical Officer. Promise Health Plan serves over 450,000 Medi-Cal recipients in Los Angeles and San Diego County, and I'm really delighted to help the discussion along and to address how do we meaningfully address the elimination of healthcare inequities and by recognizing the importance of ensuring that value-based payment for primary care has to not only measure and reward equity, but also to report not only the quality and outcomes and stratified by race and ethnicity. So I'm delighted that we're going to have this discussion this morning, or this afternoon, I should say.
Thank you, Dr. Cruz. Dr. Gottlieb.
Hi, everybody. Good afternoon. Laura Gottlieb. I'm a professor of family and community medicine and also trained as a family physician here in San Francisco. And it is such a privilege to be with you all today, to meet my fellow co-panelists, especially, and participate in this important discussion. I also co-direct a group called the Social Interventions Research and Evaluation Network, or SIREN, which is based at UCSF, but really is a national initiative to improve the synthesis and dissemination of the evidence that is accruing at the intersection of social and medical care delivery.
Thank you. Alrighty, so let's dive in. Let's start with sort of contextualizing this work. So why is it important? Can sort of we frame this work a bit more and talk about some of the key factors and considerations for social needs and primary care? Dr. Manchanda, let's start with you.
Joe, thanks. I can't wait for this conversation because I think there's a chance for all of us who are on this line, as well as those who are tuning in, to kind of learn from and provoke learning amongst each other. So let me put a couple things on the table here and invite us all to kind of do the same. Why is this important? Well, primary care, it's all about healing, right? And prevention of harms, whether it's primary prevention, immunizations, right? To prevent future harms, secondary prevention activities to identify those who are progressing towards harms, identifying risks, right? Or tertiary prevention, for our most complex patients with chronic conditions, et cetera. Primary care is in the mix of all of it, primary, secondary, tertiary prevention. It's about healing, but it's also about harms. And inequity represents the ways in which harm is disproportionately experienced and manifest in the lives of many Americans. Those harms, as we know, are due to social arrangements and structures that put people in harm's way. These harms are not accidental or unintentional even. Paul Farmer and others have characterized those social arrangements and structures that put people in harm's way as structural violence. So if these harms are socially constructed, if these inequities are socially constructed, then from that perspective, it's fundamentally important to understand for primary care to do our job in preventing harm and providing healing, to understand the social and the structural drivers, these arrangements that are putting people in harm's way. In that perspective, this is where social needs, I think, matter. Social needs for myself and for, I think, many of my colleagues here today, and for those who've been doing this work, it's not just an activity now to start to screen for something because it's something that a regulator or payer cares about. It's fundamentally about understanding how individual social needs themselves are shaped by community level social determinants, and how those community social determinants, like a food desert, are created by structural determinants, right? By supermarket redlining and other forms of structural racism, for example. With that understanding of what social needs represent, which is the individual ways in which socially constructed harm shows up in our patients' lives, the question then is, if primary care is going to do a good job, the best job possible, And if we as a society are going to equip primary care and supply them with resources to prevent harms, primary, secondary, and tertiary prevention, right? If we're going to do that, then we need to understand social needs of our patients. And we need to think about then how primary care can play its part in being able to contribute to community level efforts to address the social determinants of health. And of course, then support activities to dismantle forms of structural violence that create those social arrangements in the first place. It's in this context that I think that's how I'm thinking about social needs. It's not a side question next to about primary care. It's really fundamentally essential to what primary care is all about. And what we've been doing, and I'll put this in the chat, is thinking about how to take that framing, that broad conceptual framing, and apply it concretely into steps that primary care practices can take to advance racial health equity. And a major step in that process is to understand not just how to collect information on social needs, but then to analyze those social needs to better understand the patterns of inequity that manifest in the lives of our patients. That can help us to do more healing and to prevent more harm. I'll put a link in the chat to a resource, but that's my initial offering for the discussion.
I so appreciate that, Dr. Manchanda, and particularly the note that, you know, a lot of this is neither accidental nor coincidental, right? I think that's really important to note. Dr. Gottlieb, I wonder if you have any thoughts on what Dr. Manchanda shared.
I have so many thoughts, and first and foremost is that, you know, Rishi's comments are so spot on always, and I appreciate that framing. I'll pile on to add a few thoughts about some of the big picture payment issues that I think are super interconnected to what Rishi just shared. I think that one of the things that are, you know, this conversation that will resonate for the people who are listening to this conversation is that one of the things that we're going to have to do is right size the role of healthcare in tackling social determinants, as Rishi so, you know, eloquently pointed out. This is much bigger than healthcare. So it's going to take a lot more than healthcare payment reform. It's going to take a much deeper and broader investment, far beyond distributing healthcare dollars a little bit differently. Or, you know, it reminds me of those of you from, you know, with public health training will remember the 1978 Alma Ata international primary care work, where they really emphasized this distinction between medical care and healthcare. And at that time, even, you know, however many years ago that was, demanded a much more radical restructuring of how we invest in health and in communities. And so I just don't think we can have this conversation without the framing that more fundamental investments in communities are needed. Otherwise, we're not just, you know, we're like not just moving around deck chairs on the Titanic, but we're actually making the ship sink faster. That said, understanding that context, I would just say what I think we all are here to talk about, which is it is clear that healthcare itself can do more and can do differently. And that is, you know, that was the subject of what, you know, Chris and I were both involved in that National Academies report, where we said healthcare systems need to think about what they're doing at the community level, at the practice level, and for individual patients. All of that can be facilitated by some types of payment reforms, but payment reform is unlikely alone to change behaviors. So once we decide what's in and outside of scope for healthcare systems, generally, then we can talk about the role of primary care specifically, including the populations and outcomes that are appropriate for primary care. And then we just have to make sure that the health systems have both the money and the other capacity that they're going to need to really truly advance equity. And that's sort of the tie back, I think, to Rishi's main point. Figuring out how to structure that payment in order to facilitate capacity is obviously much more complicated. And we're going to spend the rest of the hour, I think, talking about that. So that's my addition.
Thank you so much. So, you know, if I could just pull on one of the themes that I'm hearing, it sounds sort of like no single lever is enough. Healthcare alone is not enough. Payment alone is not enough. Analytics alone, individually, these are not enough. So to me, that sort of emphasizes that partnership and collaboration are really essential, right? It sort of reminds us that no single one of us has all the answers, that we have to sort of live in this posture of learning and collaboration to collectively do this work if we're to get it done right. So I want to build on that theme a little bit and talk about how social needs integration supports patients, but also how partnership with communities and technology can help to advance integration. Dr. Matthews, let's start with you.
Yeah, no, thank you for this question. I love, let me pull the string that you just pulled, and really emphasize the point of collaboration, particularly when so much of the work that we need doesn't fit into a traditional medical model. We've come through most of our training, at least those of us in medicine, with really a focus on disease and diagnosis, as opposed to engagement and involvement. And that's truly where City Block sees its role, that first and foremost, before we start any conversation around your medical concerns, as a patient of mine, I need that trust, I need that engagement, I need to understand the community that you're in, and we need to be customizing our partnerships, our technology, even our services to meet those needs, to meet you where you are, point blank. So for us, we're scattered throughout 5 markets currently, a couple more coming online this year. The goal is really to have those relationships, those partnerships in the community with both community-based organizations, other providers, specialty care, inpatient care, so that we are actually bringing everyone to the table in a joint care team format, I would even call it, that it's only those of us in healthcare that have these divisions, these walls of specialties, of disciplines, of all of these different training settings, which are great, that have gotten us to where we are. But from a patient standpoint, they need all of our help, and they need us working together, and they need us communicating. And I think a great deal of our problem within healthcare is that we tend to stay in our disciplines. So much of what we do is try to be as interdisciplinary as possible, not just primary care and behavioral health, but bringing those community-based organizations to the table as well too, so that we can be addressing food insecurity, homelessness right at the table alongside behavioral health concerns. They're all equally as impactful on that patient's outcomes, on that patient's well-being. And of course, the way we approach this, the engagement that we have differs. We're going to have very different relationships with organizations in New York versus North Carolina, two locations where we are. And we, more than anything, need to recognize that our team members within City Block need to understand those communities and actually need to live and be from those communities. So the engagement isn't, again, just about us reaching across the table, but having the right members of our team actually connecting with those organizations, with those churches, with the food banks, and the many other services that we're able to really coordinate for our members. So I think that technology then is what is something we're feeling out. And I think in the startup world, we're having a lot of fun with it to really, again, it's about bringing down the silos of information and of data, and really introducing some efficiencies in how we communicate. Absolutely, however, nothing replaces the one-on-one engagement, the trust that we have to have. None of the members of the communities that we serve trust that machine more than they trust me right in front of them. And we need to recognize technology is not a replacement, it's an enabler. So we are going to continue to scale as we reach even more markets and to continue to refine, but we're not looking to the technology to replace that interaction that we need to really have based on the trust that we've hopefully earned as we've entered that community.
You know, that's your comments really sort of bring up to me, or bring top of mind for me, this reality that healthcare is often local, right? That's sort of the nature of this work. And so that really emphasizes the point that communities need to be partners in here, not just partners, really need to be front and center in defining what this work looks like. And I think that helps to tie into these themes of trust and credibility with these communities. I think there's a lot of work that needs to be done to establish that trust and credibility, right? So Dr. Cruz, I wonder, in this conversation about healthcare being local and you need to partner with communities, I know Blue Shield is doing a lot of work in this space, so would love to hear from you.
Yeah, well, no, thank you, and I hope I can amplify the comments of some of the other panelists that have already spoken. First, I'd like to just talk a little about sort of the integration of patient social needs into primary care, if that's okay. We know that the upstream drivers of health, which are the social determinants of health, lead to those healthcare inequities and outcomes that are reported in our data today. And I think that the Medi-Cal is the transformation of Medi-Cal through CalAIM really serves as an important first step of how we can integrate patient social needs into primary care. For example, DHCS is the agency that oversees Medi-Cal in California, has issued specific codes which allows for the reimbursement of services addressing a Medi-Cal member's social needs. And this is an important transformational mechanism that ensures that health plans and providers are able to take on that work. And it also, equally important, it provides an impactful funding stream for community-based organizations that provide those much-needed social services to continue to do so on a daily basis. And because these community-based organizations really serve as the cornerstone to address healthcare inequities experienced by communities of color and low-income Californians. When we talk a little bit about these integration of patient social needs into primary care, we also have to take a look at the value of a holistic care, not only just whole person, but also whole community approach to addressing the social drivers of health. And how do we do that? Well, taking a look at both individual and community approach, we've funded community health navigators and partnered those navigators in a variety of clinical settings, such as federally qualified health centers and other community-based agencies, so that these community health navigators work with our members and with the providers. They assist the member to identify resources to address their social needs, and we also help the member navigate their healthcare, through the healthcare system to ensure they're able to access the clinical services that they need, and also help prompt the providers of those services as to how to best meet the member where they exist, and so that's a real, from our standpoint, that's how we are beginning that process of integrating the social determinants of health into primary care.
Thank you so much. So we've talked a lot about partnerships, communities, whole person care. I want to pivot just a little bit and talk about sort of payments role in facilitating all of the work that we've talked about thus far. I know we highlighted that payment alone is not enough, but the event does have a payment focus. So just want to talk briefly about the role of financing and payment. What's been done that's proven effective, right? What holds promise? Dr. Matthews, let's start with you. I know CityBlock's model is really built on this idea of value-based care, right?
Yeah. I love that I've been able to kind of move between multiple worlds in my career, and having shifted from the VA being this very large bureaucratic and of course government sponsored program to now this value-based model. What I'm most excited about is that both models actually, I believed, afforded us the opportunity as care teams to really step away from this financial conversation that unfortunately a lot of at least the other practices I were in were more at the forefront of my day-to-day. At City Block, we partner with payers across the country. That is really the relationship that we then carve out to have capitated risk to be able to take on the most complex populations that they're working with. So we are taking SMI, we're taking SUD, we're taking all of the lines of business that are definitely the poorest outcomes first and foremost, but of course, highest utilization, highest cost, and are accepting both down and up and downside risk in order to truly be able to show a difference through our model. And indeed, we're doing that. We are decreasing hospitalizations, we're decreasing emergency department visits. And while those are administrative, and we know there's a significant number of other quality outcomes that we will be looking at as well, particularly in the primary care space, we have to acknowledge, at least in these communities, getting these patients into an established relationship, again, where they have that trust and engagement, again, where we can actually address their social needs, we are making the impact that we ultimately want, while also decreasing unnecessary utilization. This isn't a gatekeeper function. This is really more making sure we're directing them to services that are necessary. So as part of our model, we're able to set up the services that make the most sense. We have established an ED at home program where we're actually sending EMTs into the homes instead of having our patients go into emergency departments. We were well on the way through our virtual services, and then of course the pandemic hit, and we're all there now. But really having these services that are really ingrained in the community, and even meeting some of our patients on foot at park benches even is something that we're really trying to prescribe to, again, be able to meet the member where they are. None of that is as easily possible, or if at all, under a different financial model. Unfortunately, the fee-for-service structure really, unfortunately, restricts other providers a little too tightly versus we're able to really be as innovative. We're able to explore with risk, of course. So, this means we need to approach it with evidence and the intellect and the support, of course, that we have from our investors to be able to do so. But we really do believe by focusing on these high cost patients, we're addressing most importantly their quality outcomes, but we're addressing their needs and the overutilization. And actually, more than that, the dearth of focus that they're receiving in other respects. They have a primary care practice with us now, and we're able to do so at a very different financial margin than others might be able to.
What you all at the City Block have accomplished is really, really impressive. And I am so excited to watch you all continue to grow. And I think some of your comments too sort of highlighted the weaknesses of fee-for-service, right? A lot of this work can't be done under a fee-for-service structure, and COVID really sort of exposed the vulnerabilities of that system. A report came out last year, I think it was from the California Healthcare Foundation, maybe it was the year before, that said at least in California, a third of primary care providers reported that they were at risk of closing because they weren't able to get patients in their doors. And that's really, it's just a scary number to hear. So
if I could even piggyback on that, Joe, yeah. Sorry. I think one of the fundamentals of our model is that this is not about just getting the patients into the door. And in fact, the door is irrelevant. We accept risk for a population of members, no matter where they are. And we know the overwhelming time that these patients spend is not in our offices, is not visit-based. And we have responsibility for their outcomes, whether or not they're engaged with us. So there's outreach efforts. We have a couple of members, I hate to brag about this, we have a couple of members that we've had phone calls out to get them established in our care close to 40 times, and we will keep calling. Part of the problem with our primary care system is that we wait for the patients to come to us. And so our model in accepting risk across a full population is that we will not wait. We will find those patients. We will go to that park bench to talk to the homeless gentleman because we need to assure their well-being and assure their outcomes. So I think part of the model, again, is that we are so provider and productivity based within our own walls in more fee-for-service settings that it really does a disservice to the larger population, to the larger community. And that's what we're talking about when it comes to equity concerns.
Dr. Gottlieb, I know you shared at the beginning some thoughts on payment. I wonder if there's anything you want to build on here.
I do. First, I just want to say kudos to City Block. And the work that you all are doing is so exciting. And I hope will inspire lots of other people to do things differently. I do want to just emphasize that I think on the payment side, City Block is pretty exceptional. And that's, I hope, why we're seeing you scale, because you're doing such good work. But it really has been more like 1,000 flowers blooming in terms of the different kinds of payment experiments that we're seeing in this field. So, so what is it? It's maybe it was Cindy Mann who said, like, you've seen one Medicaid waiver and you've seen one Medicaid waiver. Like, they're all so crazy different. And that's just an example, right? So we've seen of the kinds of innovation that we're seeing around addressing social determinants. So yeah, Medicaid waivers are an example of that. And Sahil Sandhu actually kind of has a great summary of all the different ways in which different waivers have incorporated activities related to social determinants in one of his recent papers. But we're also seeing lots of state Medicaid agencies incorporate non-waiver related strategies for addressing social determinants into their contracting and procurement. Yeah, again, outside of waivers. And those are just span the gamut. So there's like, do what you can, or do something very specific, screen for this social need, incorporate community health workers, or do something related to health equity, do something at the patient level, do something for communities. So Arizona in some of their contracting, I think they actually have a specific requirement around community level investing. It's all over the map. And it's really, I just would say that we're a long way from proven effective. The reason we're seeing so much experimentation is because we don't 100% know what's gonna work. And it's not just in the waivers or in the contracting and procurement. We're seeing these like very specific strategies for social risk adjustment, like in Massachusetts, or all this new conversation about social screening and action quality measures that are coming out, not just from NCQA and CMS, but also the Joint Commission. And there's just so much dialogue about the different strategies that we would use to pay people for this work. So I would say it's incumbent on us to learn from those 1,000 payment model flowers. I don't know, are they flowers? I don't know, but 1,000 different payment models, and just make sure that we're looking not only at what makes us do more and do differently, but really what is achieving equity. To go back to Rishi's original point, which is like, this is about achieving, the implicit assumption with all of this work was that we would advance equity, but we haven't actually, in a lot of our research and studying on social determinants interventions, we haven't always consistently looked at equity as an outcome. And I think that that's kind of the direction we need to go. And then I'm just gonna hit that nail again, or use the same hammer, or I don't know what the expression is, to say that we need both financial and non-financial supports. And I just want to share a couple of very concrete examples. And one of them I see Amy just put into the chat, but flexible payments don't mean adoption. It doesn't mean that, if you set up a flexible payment option, in the City Block example, they've run with it because they really deeply believe that this is the right approach. But we've set up flexible payment or value-based payment in lots of other ways. And folks who are not as deeply embedded in their communities are not necessarily taking up those options. So Amanda Brewster, Crook, Myers, there's like several papers showing that supplemental benefits adoption is not how, in Medicare Advantage, for instance, has not been through the roof. Like people are not like running away with us. Teresa Fraze has a paper that shows that ACOs are not consistently doing this, even though they're sort of built around like, well, do something, do the right thing, we're giving you flexibility here. And then I think that, Oregon is another great example where they're, even under their waiver, the adoption of health-related social service payments actually didn't go through the roof. And Ann King in Oregon has been looking at that in great detail. Like, it's hard to get people to change behaviors. And then Amanda Brewster, the other article I would throw into the chat is actually her article showing that it actually was practice innovation capacity more than value-based payment opportunities that led practices to do something different in primary care. So we have to think about all those other things. We need tech capacity, like Cameron was mentioning, we need patient engagement structures, we need technical assistance, and we really need to support these systems around innovation. So that's my nail, and I'm hammering it.
We appreciate you hammering that nail. I think your comments, especially around sort of let 1,000 flowers bloom, it does seem to me like some frameworks or some guiding principles could help ground us and what we think is most likely to have promise. So Dr. Manchanda, we've talked before, and you've shared that you have sort of some framework, right? Like value-based, equity-based. I'd love if you could just sort of expand upon that for the audience and sort of bring a bit of framework to what Laura was sharing, Dr. Gottlieb, was sharing.
Yeah, well, I think first, plus one to everything that's been said, including the last point. Health Begins has been from the get-go, especially in the past 5 years, dedicated to providing the capacity building, the technical assistance, working very much alongside the courageous leaders within both healthcare institutions and community-based organizations, the social sector, to think about how to address the capacity issues, even while the payment reform conversation continues to play out. It underscores the point that payment reform is necessary but insufficient. It speaks to the fact that infrastructure, capacity, practice level transformation, payment transformation, and policy transformation all have to be operating at the same time. And that comes both from the evidence base that's being codified in the research that Laura kind of listed out, but it's also from the evidence that's being generated every day by those who are on the front lines of providing and receiving technical assistance. So there's a lot of insights, and some of the insights kind of boil up into one particular point here that we have a lot of payers here as much as those who provide primary care on the line today. And I will say that what we've recognized through all of these kind of engagements over the past several years has been that one of the original sin, if you will, going back to Alma Ata 1978, and since then in American healthcare design, has been the fact that we've removed place as any kind of organizing principle in how we think about payment and resource allocation and care delivery. Having said that, we do have some incredible examples, counterfactuals, right, with community health centers, for example, being the prime example of what it means to actually organize healthcare by place and to look at health professional shortage areas and MUAs. So we do have a lot of American homegrown experience that is counter kind of factual to what is the dominant model, which is unmoored from place. And what we've seen is when we think about value-based payment reform and how to insert equity into value-based payment reform, that one of the things that can help unlock the necessary administrative organization within plans and the necessary kind of clinical provider relationships, and frankly, community provider relationships, is using place as a way to start to understand your data, understand your resources, and then align your strategy. So concrete example, to what extent are payers right now able to support practices to not just provide incentives to collect social needs and to make sure those incentives, to Laura's point earlier, are are heavy enough of a dose, right? If you're already underpaying for primary care and you provide just a little eking of incentives to screen for social needs, that's not going to be enough to kind of incentivize fundamental changes in behavior. But there are mechanisms by which plans can actually take the incredible data that they have and start to understand if the inequities, for example, inequities in maternal mortality, inequities in diabetes outcomes, inequities in access to post-hospitalization kind of discharge care, these inequities, including specifically racial inequities, can then be analyzed by place. To what extent do these inequities vary by census block or tract? If they do vary, then they're more likely to have social and structural drivers. And to what extent can you then leverage area-based social risk data, right, to provide the prospective payments, right? Whether through capitated models like is happening through City Block or otherwise, provide these prospective upfront payments to allow practices to start to align their work on to address these inequities at the level of the practices, and also to align with other providers, both clinically and community-based, to start thinking about new ways. At the VA, for example, when I was working there as a frontline kind of clinician, we had a model requiring us to improve outcomes for homeless veterans. This was about 10 years ago. And because of the payment environment that was there, we just had to do the best job we could. And when we looked at our data and we geocoded the data about where our vets, the homeless vets, were coming in, we realized that the top 10 unmet needs that were experienced, they were legal and social. And so we brought lawyers in and social workers in and made them the lead of the clinic. Our outcomes, primary care outcomes, improved dramatically, return on investment improved dramatically, and most importantly, the patients got better. One of the giants of primary care, Tom Bodenheimer, came to visit us in that clinic and quote, said, "This is the highest level and most compassionate care I've ever witnessed," unquote. When you when you use social data, not just to kind of screen for these things, but then to start looking at what this means by place and start mapping out using social needs to get better insights into the drivers of inequity, and then allow as payers the opportunity to let practices with prospective payments sizable enough to be able to reorganize care addressing the needs of their patients, then you can do more things that City Block is doing right now through private money, right? But to allow more people to actually have the ability to organize themselves by place. The last thing I'll say on the payment side is innovation is one thing, but sometimes it's just getting rid of the barriers to innovation. So for example, how do we pay for community providers in the context of CalAIM, Dr. Cruz, right, to provide care provide the community support services, the social services for Medicaid members in California, not unlike conversations in other parts of the country. Payers right now are reinventing the same kind of broken approaches to contracting with community providers that we've seen to be inequitable and ineffective with clinical providers. If you're a primary care practice, you already know what it's like to have to respond to 7 different payers. We don't want community-based organizations to have to do the same exact thing. This is not the time to reinvent the fee-for-service inequities, right, and the structural violence that is created by them into the social sector. We can actually do no harm as payers by being able to at least and provide more opportunity for innovation by saying, well, maybe we should invest more in the capacity and the infrastructure of intermediaries, of technical assistance to support more equitable relationships between those who provide social services and how they relate to primary care. In other words, there's a lot of things that we can do to release innovation, starting with just not doing harm by taking the medical model of contracting and applying that now to the social sector. That's one way, for example, to do payment reform. The fundamental point is where I started with organizing by place is helpful, and with plans we've been working with, we're seeing how place can be helpful using a concept we call health equity improvement zones to help start thinking about how to apply data analysis, identify the inequities, organize resources by place, and then engage your providers, provide them prospective payments, and support your social service providers as well to start thinking about how to address collectively impact on inequities that are defined by place and not by payer type or by payer specifically, excuse me.
Yeah, Dr. Manchanda, your comments again sort of emphasize to me the need for alignment among payers, right? Not sort of repeating the burdens of fee-for-service and the proliferation of requirements that we've seen on primary care providers, not repeating that with community providers, really emphasizing that payers need to work together and then work with their communities to make sure that transformation efforts, reform, whatever you want to call them, are having the impact that we intend them to have. Dr. Cruz, as a payer, I'd love to bring forward that payer perspective. I know that Blue Shield has some community health advocate work, as you mentioned earlier. We have some partnerships with technology vendors, and a lot of that, right? It's all intended to get at this issue that we're talking about. So curious if you have any thoughts about sort of the intersection of all of that work that we've been talking about with payment again.
Yeah, no, thank you. And I just want to say, the comments of Dr. Matthews and Dr. Gottlieb and Dr. Manchanda, those messages that they're sharing really, we need to amplify them. And in one area in particular, I want to amplify Dr. Gottlieb's comments that payment alone cannot overcome the barriers to social care, and that other supports are needed. And that's a very critical realization that payers have to recognize. We've taken a first step, and it's not the only step we're going to need to take, but it's a first step, and I think it's an important first step that we've partnered with community health advocates that we just discussed a little bit, and also with Unite Us. Because it's important that we ensure that we're able to impactfully support the work of community-based organizations and provide the community-based organizations with the resources they need to address a member's social needs. A lot of community-based organizations don't have the infrastructure or the resources to submit a claim or to collect data on the members that they serve. It's not the typical mechanism of how they've provided services and historically. And partnering with Unite Us, for example, they serve as a valuable intermediary that's able to provide the support and collect the data on behalf of those community-based organizations and submit claims on their behalf, so that the community-based organizations can be reimbursed and really have a sustainable resource stream, so they can serve and expand their reach. Also, I just want to say a little bit about value-based reimbursement for primary care providers, and we are working on restructuring our value-based reimbursement for primary care providers. It's important that as a plan, Promise Health Plan, we do so to ensure that we incentivize providers to have the adequate time to both provide clinical care and have that meaningful discussion with patients, so we can elicit their social needs, and to do so without penalizing the provider for factors beyond their control, or that the reimbursement has a negative impact on adoption of screenings or prevention or other things. It's important they have time to do both. They can't do it all, but we need to be able to support to do both, because the primary care providers are still a very important component, and patients do want to share that information with their primary care provider. And sometimes that's the only provider that they want to tell it to first. And so we recognize that, and we want to support that. So thank you for that question.
Sure. Yeah. Thank you, Dr. Cruz. I mean, some of your comments tie earlier to what I heard from Dr. Matthews around this concept of trust, right? Really needing to trust the communities, the trust and the credibility between communities and the healthcare and non-healthcare entities that they work with. So we do have just a few minutes left. So I just want to transition a little bit to more of an audience Q&A. We do have one from the audience here. And I'm going to ask this question and also contextualize it, because I think it ties to another theme that we've heard today. So this question here is, what are your thoughts on payment codes for social needs being seen as individualizing public health, which may not be effective or may delay public health and population level intervention? So there's the audience question. I think it ties to this larger sort of issue of unintended consequences, right? Like good intentions, bad outcomes. We know healthcare is rife with perverse incentive. So let's have that conversation. So like, what are the sort of perverse incentive pitfalls that we need to think about? Is there potential for this work? For example, like payment codes to incentivize maybe the wrong behaviors or produce bad outcomes rather than the outcomes that we intended them to produce.
I'll share a few thoughts on that, Joe. I think that it's important that it be recognized that having these codes to provide reimbursement for social needs does not negate the importance of funding and supporting and rebuilding our public health capacity that's really been severely depleted during COVID. And yeah, it's while it may be a not an ideal step perhaps in some eyes, it's an important first step. Because before they were totally disconnected, addressing social needs from primary care. There was no connection between the two. And now to be able to bridge that gap between being able to reimburse for social needs and healthcare in the same type of in the same site of service or within a group of providers that work collectively or in partnership. That's an important first step. We can build upon that, and we will build upon it and do better. But again, I just want to emphasize that individualized public health, it does not. I don't see it as or should not negate our rebuilding our public health infrastructure that's been so severely depleted because of COVID.
Can I build on that just briefly? I think it's such a great question because many primary care practices, including the ones I've worked in, are already addressing social needs or at least identifying them. It's coming up in many ways. The question is whether that's work that's going to be documented. And so there are the E&M codes, obviously, that came out in this past year, allow now for more opportunities to at least better code for some of these social risks in one way, shape, or form. That coding is essential, but it's linked to the second part, which is that it's problematic if there's an assumption there that if we're paying then for the screening and paying for the individual addressing of those social needs, we're letting remain dominant the fee-for-service kind of model, rather than paying for a bundle of care and then saying code for these issues, but treat them differently. It's a much more difficult, I think, proposition to think about how to contort social need payment into a fee-for-service system. And that's where the payment question comes in. And the third last point is that from a population health perspective and to the broader public health perspective, Dr. Cruz, that you spoke about so well, I think the social needs that show up among our patients aren't truly representative of the social needs of our patients. The patients who show up, right, aren't not necessarily representative of all of the patients that we need to care for. And so there's a risk that relying over heavily on just the social needs that we screen for and identify among patients who do show up is adequately representative of the true kind of level and prevalence and severity of unmet social needs as they manifest across the community that we're supposed to be serving. This is, again, a failure of a place-based approach rather than just letting it be a practice-based approach. So coding is necessary. Coding is necessary to inform policy and population health and to inform place-based interventions, but the way we pay for it needs to be thoughtful. Prospective payments, bundled capitated payments rather than individual fee-for-service, and then also making sure that we don't overly rely on social needs that show up in practice to be illustrative of the true level of social needs in the community. Those who are not being screened need to be as much in our minds as those who are.
Yeah, Joe?
By all means, jump in.
Chris, I want to call, Cameron and I were fortunate to work on the primary care, implementing high quality primary care committee with NASM. And I want to call attention to sort of a stealth recommendation. Everyone got all bent out of shape about payment and hybrid payment, was it right, was it wrong? But the first recommendation that was made under access was that plans and payers and providers and and patients themselves should get themselves used to declaring a usual source of care. And I think that gets us towards what Rishi's talking about, which is a place-based approach. It may be, Rishi, it could be like that begins a practice-based, but then we can expand that to place-based. And we just, I would encourage the plans that are on the call to dream bigger. I take what James is saying really true, that yeah, paying for social services is great, but don't stop there. I mean, we have got to create this, what can plans do to facilitate an accountable relationship both ways between clinical teams and patients, because that starts to create the accountability, that place-based sense that Rishi is talking about. And anything that we can do to build that. And that's often been toxic. The plans haven't wanted to touch that because, oh, that's gatekeeper, it's managed care and stuff like that. No, it's a relationship that we saw in the committee was absolutely essential to developing the kind of population-based approaches that we've been talking about here.
I'll just, Joe, if I can just.
Sure, yeah.
I know you're going to have to close in just a moment, but I will just say this question is sort of, it hits at the heart of so much of the complexity of doing this. You know, it's true, perverse incentives abound in the healthcare system, and it's certainly not just around the codes. It's around, you know, the whole conversation about quality measures. And are we going to incentivize people to screen, but not, you know, not have a quality measure that is, and document, but not have a quality measure that's about, I screen in a way that, you know, improves the patient's experience and relationship, that where I no incentive or quality measure that is about, I did something about this, whether, you know, changing the medicine because they couldn't afford it or helping them afford it. You know, like there's so much that needs to change. And some of it is about the payment system, the, you know, practice, the way we shape practice. And so much of it is about the community investment. And so I think the answer to this person's great question is it's a yes, and there's so much to do. And this is, you know, that's one piece, but I don't think anybody on this panel would say that is the piece. That is one piece of what needs to change.
Yeah. Thank you all so much. I think that's the perfect note to end on. Yes, and lots of work to be done in this space, and need to do it all together. So thank you all so much for your engagement today. Thank you to my panelists who have been here with me. We so appreciate all of you. Thank you to Milbank, Chris, and Rachel Block of Milbank in particular for your partnership. Don't forget to register with your email so you can get the recording of this event, and to sign up for our newsletter so you can follow our future events where we'll dive more into social determinants and all. Thank you all so much, and we look forward to seeing you all again soon. Bye.
Thank you. Bye.